Hello, everyone. Thank you for joining today's 2023 Quality Payment Program Physician Fee Schedule Proposed Rule webinar. This webinar will provide information on the proposed rule and proposed changes for the 2023 performance year. It will provide an overview of CMS's goals for the future of QPP, walk through the 2023 proposals for the Quality Payment Program, and offer resources for help and support for submitting comments about the proposed rule. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone in the Q&A box, and CMS subject matter experts will address as many questions as time allows. You are welcome to submit questions during the presentation or wait to submit your questions until the Q&A portion of the call. Now, I will turn it over to Dr. Michelle Schreiber, Deputy Director of the Center for Clinical Standards and Quality, and the Group Director for Quality Measurement and Value-Based Incentives Group at CMS to begin.
Olivia, thank you, and good afternoon, everybody, or good morning to those of you in the Western time zones. Thank you so much for joining us today for the Quality Payment Program webinar on the 2023 Physician Fee Schedule Proposed Rule. It is a proposed rule, and there is plenty of opportunity for everybody to make comments. We have over 2,000 people registered for this call, and we're very excited to have you join us today. Our CMS experts are on the line also to try and answer your questions, and I encourage you to submit your comments about the proposed rule in writing in the normal process so that we can be logging on for each of those comments and responding as appropriate in the final ruling. As Olivia pointed out, I'm Dr. Michelle Schreiber. I'm the Deputy Director of the Center for Clinical Standards and Quality, and I also lead the Quality Measurement and Value-Based Incentives Group. We're very eager to share our proposed changes to the Quality Performance Payment Program so that you can start thinking about how you would like to submit comments and how you would like to participate in the future. I do want to start by saying we certainly recognize the continued challenges faced by many clinicians across the country for the past 2 years. And on behalf of CMS, we deeply appreciate everybody's efforts in helping to combat the pandemic. As we move forward together and look to the future of the QPP program, CMS remains committed to promoting more meaningful participation for clinicians and ensuring that our policies continue to drive us toward value and improved health outcomes for all individuals. To further these goals under the MIPS program, the Merit-Based Incentive Payment System, we're focusing our proposals on continuing the new MIPS value pathways, or MVPs, and refining the subgroup participation option. We continue to propose very limited changes to traditional MIPS to provide clinicians with continuity and consistency while they gain familiarity with MVPs. We will also be talking about the Medicare Shared Savings Program, the ACOs, in today's presentation. So let's review a few highlights from the proposed rule. For the MIPS value pathways, the MVPs will allow clinicians to participate in MIPS by reporting on a set of meaningful, cohesive measures and activities. The goal of the MVPs then is to ensure clinicians participate in QPP in a way that makes sense for their practice. In the calendar year 2020 PFS proposed rule, actually last year we finalized the first of 7 MIPS MVPs that will begin next year in the 2023 performance year. And in this proposed rule, we recommend revisions to all of those. We are also proposing the addition of 5 new MIPS value pathways, one for advancing cancer care, one for optimal care for kidney health, optimal care for patients with episodic neurologic conditions such as epilepsy, supportive care for neurodegenerative conditions such as Parkinson's disease, and a very important MVP for primary care physicians and clinicians on promoting wellness. We're also proposing additional policies related to MVP development and maintenance, to subgroup reporting, and expanding the MVP inventory to support more meaningful participation for clinicians and improved outcomes for patients. We'll clarify how team-based care in the patient journey can be reflected within MVPs. For traditional MIPS, again, to provide continuity and consistency while clinicians gain familiarity with the MVPs, we're proposing very limited changes to traditional MIPS. The updates mainly focus on reporting requirements and scoring policies to help clinicians meaningfully participate in the program. For example, we're proposing to update the measure reporting requirements for promoting interoperability. That makes the query of prescription drug monitoring programs, PDMP, those state registries. It is a required measure in this proposal, beginning with the 2023 performance period. Also, in allowing the alternative payment model entities to report promoting interoperability at the APM entity level. And as I noted for MSSP, we will have our experts on the line today to discuss updates to that program as well. As part of the 2023 PFS proposal, we have also formulated several requests for information, or RFIs, in priority areas such as health equity. We really encourage you to review these RFIs and provide responses back to CMS to help us shape the future of the quality payment program. One of these RFIs is the MIPS quality performance category for health equity, focused on collecting feedback on the development and implementation of health equity measures for the quality performance category, as CMS seeks to enhance and increase the number of measures in future years that address or incorporate factors pertaining to health equity. In other words, how can all individuals achieve their maximal health outcomes? Finally, in closing, I'd like to again thank you for joining today's session, and please consider submitting your comments in the proposals you're about to hear about. I will now pass this over to Katie Moore, who is the QPP Engagement Team Lead, and she'll provide more details about today's webinar and comment submission. Thank you, and Katie, I pass it to you.
Wonderful. Thank you so much, Dr. Schreiber. We really appreciate you kicking us off this afternoon or this morning for our West Coast colleagues on the line as well. Good afternoon, good morning, everyone. Really appreciate you all taking the time to join us today. And I know we've had a few comments in the QA box. Don't worry, I know Dr. Schreiber went over a lot of important information, but we are going to cover it throughout the rest of these slides. So don't worry, you didn't have to furiously be writing down all the important information she was sharing. We will get into more detail on our slides. And with that, let's go ahead and get started. We can move forward, I think, 2 slides. Okay, great. And as everyone knows, the physician fee schedule proposed rule was recently released, and today we are going to be covering all things quality payment program in that rule. So as Dr. Schreiber mentioned, and you'll hear several times today, the key date to keep in mind is September 6th. So that is the deadline for all formal comments to be submitted to CMS through the formal comment process. So we really need all of your comments and feedback in writing through this process. And again, there are instructions here on the screen and in our resources, and as well as in the proposed rule itself. So we are happy to have discussions today as much as we can, knowing that we're in rulemaking, and answer as many questions as we can get to, but really encourage folks to submit comments through this formal process. And just a couple other kind of housekeeping things before we get started into our other slides today. As always, our slides and recording will be posted usually a week or 2 after the event on our QPP webinar library. So don't worry about trying to write down everything you're seeing on the screen. These slides will be available later. And if you haven't noticed yet, in the chat box at the bottom, you aren't able to submit anything in the chat box, but please keep an eye on it, because you'll see a lot of helpful links as we're going through and talking about different topic areas. Eve is graciously adding links to different resources that we have available. So encourage folks to keep an eye on that. And then you'll also see our Q&A box. And I see that a number of folks have already submitted questions to us. So we have a lot of our CMS subject matter experts on the line today. And throughout the presentation, we are going to try and answer those questions as they come in. And we will definitely have time at the end for our QA session where we'll go over some of those questions. And then hopefully folks will join us live to answer questions over the phone. All right, next slide, please. Okay, just a quick run of show what we're going to cover today. I will touch on a few slides about just future direction of QPP, some overview background information for folks joining us today that are newer to Quality Payment Program or maybe just participating in the program for the first time or just looking for more information about the program. Then we'll get into some more details about our MIPS value pathway proposals, so MVPs, and then our traditional MIPS, so merit-based incentive payment system proposals, as well as our advanced alternative payment models, so APM proposals. And then we have a couple slides just on public reporting updates in this proposed rule, as well as a few slides on our shared savings program. So stay tuned through the end for all of that. And then we'll round it out with some help and support, where to go for more information, some additional links there, and then we will open it up for Q&A. Next slide, please. Okay, so we all know we recently released this rule, and as Dr. Shriver mentioned, we are continuing to focus on development of new MVPs and refining the subgroup participation option. So you'll hear a lot more on this topic from Sophia Sugumar, so I'm not going to talk too much detail about these, but you will see more in future slides. Next slide. And then just real quick, few top-level, high-level policy highlights. So as we've mentioned, we really wanted to limit our changes to traditional MIPS this year as much as we could, and not just making changes to make changes in the program, and to really provide that continuity and consistency with our focus being on this transition eventually to MIPS value pathways. So things like that we've kept the same. We're continuing to use our mean final score from 2017, so our performance threshold has not changed. So we are proposing to keep it at 75 points for 2023. We're increasing our data completeness threshold to 75% for 2024 and 2025, updating our MIPS quality measures and improvement activities inventory in a couple of different ways. And then we have some updates for requirements for promoting interoperability performance category, and then establishing a maximum cost improvement score of 1%, 1 percentage point out of 100 percentage points for cost performance category, starting with 2022. So all of these definitely have more details in further into the presentation. Next slide. Okay, and I think I have a slide, a couple forward about all the different RFIs that we have in this proposed rule as well. And then our CMMI colleagues will definitely get into more details on advanced APMs and some different changes we have there. Next slide. One more. Okay, so the next couple of slides for folks that have been with the program for a little while now or have attended several of our events, these will look very familiar. Or if you've gone to our resource library and seen a lot of our resources, we always try to start these bigger presentations with just a couple overview slides to really ground us in background on the Quality Payment Program, especially if we have new folks joining us today. So this slide we use a lot throughout our resources and just describes what the Quality Payment Program is at a very, very high level. The Medicare Access and Chip Reauthorization Act of 2015, which we refer to as MACRA, ended the Sustainable Growth or SGR formula, which would have resulted in significant cuts to Medicare
payment rates for clinicians. So what MACRA did was created the quality payment program, and there are 2 tracks that clinicians participate through. So there's the first track, MIPS, which is the merit-based incentive payment system, and then our advanced APM, so alternate payment models. And then I think the next slide gets into a little bit more detail on which clinicians that participate through advanced APMs also participate in MIPS. Next slide. Okay, so this diagram really helps us explain this overlap that we see for some clinicians that participate in MIPS and are also in an advanced APM. So there are clinicians that are in advanced APMs. So if you achieve QP status, which is qualifying APM participant status, you are excluded from MIPS and will earn that 5% APM incentive payment. And then if you are a partial QP, you have the option. You can choose to participate in MIPS or not. So if you do not achieve QP or partial QP status, then you are in an advanced APM and do not achieve one of those statuses, then you are required to participate through MIPS. Next slide, please. And this just provides a little bit additional detail or similar information, just shown in a different way. And this designation of the APM doesn't affect clinicians' eligibility for MIPS. So APM participants still need to participate in MIPS unless they receive that QP status or are, for some other reason, exempt from participation in MIPS. Next slide. So again, just talking through some of the future direction we have outlined in our proposed rule this year, we really do acknowledge all of the different challenges and just struggles that our country as a whole and the world as a whole, but really our healthcare community has faced over the past 2 years. First, just want to thank everybody for everything you've been doing to help us get back on our feet after this pandemic. Or continuing to get back on our feet. But as we look to the future of QPP, CMS, as Michelle mentioned, we really are committed to promoting more meaningful participation for clinicians. We want you all to practice in a way that makes sense and that really is meaningful for you, not just submitting measures to submit measures. They really are relevant to how you practice. So we're ensuring that our policies continue to drive us towards this value and ultimately to improve health outcomes for all patients. And to further these goals under MIPS, so as we've been talking about and we'll continue talking about throughout this afternoon, we're continuing to focus on this transition to MVPs and developing new MVPs, refining the subgroup participation option, and then really reducing burden to facilitate participation into APMs. Next slide. And here just listed out, we've referenced a little bit, but our request for information, where CMS is listing feedback. Some of these you may have seen similar in other rules, but we really encourage folks to read through them, see what questions we're asking, where we're looking for feedback, because CMS as an agency, but definitely the quality payment program, we really rely on this feedback and information from our interested parties and all of our different partners as we develop our policies and our programs and our systems. We really need this feedback from you all to make sure the direction we're going really makes sense for clinicians across the country. So encourage everybody to take a look, read through these, and submit through that formal process we discussed. Next slide. Okay. Oh, I think we can back up on, there we go. Real quick before I turn it over to talk about MVPs, just wanted to also flag for folks a couple of things to sign up for our QPP listserv. If you haven't already done so, that's where we put out all of our most recent information and announcements about the program. So encourage folks to go to our website, qpp.cms.gov, to sign up for that. And Also, if you are a small practice or work with small practices, we have a brand new small practices newsletter that we send out monthly. So encourage folks to sign up for that as well. And with that, I am going to turn it over to Sophia Sugumar to talk through our MVP proposals.
Thanks so much, Katie. Next slide, please. Okay, to get us started on our MVP proposals, we want to just set a reminder that we previously in the calendar year 2022 final rule had finalized what an MVP participant is. And an MVP participant is a term we've coined to encompass several methods of reporting at the individual level. It covers single specialty groups, it covers multi-specialty groups, subgroups, and APM entities. And just a little note for the multi-specialty groups, we previously did finalize that beginning in 2026, a multi-specialty group would be required to form subgroups in order to report on MVPs, but that's just a little side note there of a previously finalized policy. What we are proposing in this rule, in the calendar year 2023 rule, is to then identify the data source, which would help us distinguish a single specialty group from a multi-specialty group. We previously proposed the utilization of PACOS, but received a lot of stakeholder feedback with citing concerns regarding that data source. So within this proposed rule, we are proposing to utilize Medicare Part B claims data as the source for determining specialty type. So to define what a single specialty group is, we would then leverage the use of the data source to then indicate that there's only a single specialty identified. If we identify more than one specialty through the Part B claims data, that would then make us follow the determination that that group is a multi-specialty group. So a multi-specialty group is a group that consists of two or more specialty types as defined by the Medicare Part B claims data. Next slide, please. As Michelle, Dr. Schreiber has previously discussed, we did propose updates to our 7 previously finalized MVPs that were finalized through calendar year 2022 rulemaking. The details of those updates are included in the QPP resources that for the calendar year 2023 rule, and also available in the appendix of the rule. There's an MVP section of the rule. There are additions and removals related to measures and improvement activities, and the updates typically are in alignment with the updates to the measures and the activities inventories that we are making in the traditional MIPS side of the house. In addition to updates to previously established MVPs, we are also proposing 5 new MVPs to be available beginning with the calendar year 2023, and they cover advancing cancer care, kidney health, episodic neurological conditions, and neurodegenerative conditions, as well as promoting wellness, which is a primary care-based MVP. Next slide, please. As mentioned, we are looking to make some modifications through this proposed rule related to our engagement strategy for MVP development and also separately MVP maintenance. So within this slide, we talk about revisements to our external stakeholder interested parties engagement, in that we would, in the process of developing new MVPs, we would work collaboratively with stakeholders who submitted those MVPs. But after that process is completed, we would then publicly post for a 30-day comment period any MVPs that CMS has identified as viable for a larger cohort of stakeholders and interested parties to then provide feedback on. And these would be posted in our QPP resource library and really would provide the opportunity for interested parties of diverse opinions, various stakeholder party types such as patient advocacy groups, various specialists or specialty societies, hospital organizations, or even third-party intermediaries such as EHRs, to then really provide their perspective on and input as to if there's something we should consider before we move forward with a policy proposal or MVP proposal in a future rulemaking cycle. We also, within this proposed rule, clarify through some additional information how an MVP can be constructed to really reflect the team-based care model. We do continue to support team-based care and the utilization of team-based care in our practices that are participating in the MIPS program. So we want MVPs to the extent to reflect team-based care, that there's possibilities to involve several specialties in MVPs, and our reporting allowances do allow for these various clinician types to report on the same MVP so long as it's clinically relevant. So we do provide some additional language related to that to provide some clarity as well. Next slide, please. Separately but related, we do also propose updates to our MVP maintenance process, and we have previously finalized MVP maintenance process where we would allow stakeholders to submit to us their recommendations on how we can update previously finalized MVPs through a written process where they would submit their feedback through email. We are then proposing an update to that process where, in addition to the previously established process, we would also add an opportunity for us to then host a webinar in which we would then identify any feedback we found to be viable and then kind of just have that up for discussion during the webinar and allow those interested parties to participate in that webinar and provide any potential feedback they would like us to consider. Next slide, please. Within our subgroups policies, we previously established a definition of what a subgroup is. In this proposed rule, we're looking to now provide some clarity through a proposal related to subgroup eligibility. I think we've heard that there's some questions as to the timing of MVP and subgroup registration, which begins in April and ends in the end of November, and how that kind of is a bit different from the timeline that is used for eligibility determinations. So we want to be clear that subgroups, even if they are unaware of their final determination of eligibility, can still register leveraging the results of their first segment run of MIPS determination. If they find through that first run of first determination run that they are considered MIPS eligible, they can continue to register as a subgroup and track to that. It'll ultimately be the second run of eligibility determination, which then decides whether or not that subgroup can participate in MIPS, but we would at least want to allow them the flexibility to register if they feel that they would like to participate in MVP reporting as a subgroup. In addition to the eligibility proposal, we also have a proposal related to subgroup registration. We proposed to revise or modify the subgroup registration requirements. We previously finalized in the calendar year 2022 rule that the subgroup registration must include a list of the 10 NPIs within the subgroup, a plain language name for the subgroup, and a description of the composition of the subgroup. We are proposing to add, to clarify, we are proposing to add a third element, which is that the subgroup would then also be required to describe through a narrative or a drop-down list, the composition of their subgroup to really help us for informational purposes understand how the subgroups are being formed. Are they considered of multiple specialties? Are they considered of various clinician types such as nurse practitioners and clinical social workers? And we'd really like to understand how our MIPS participants, MIPS eligible clinicians and groups are participating in MVPs. So that's really more of an informational element that we thought would be of value. In addition to that, we are also proposing that a clinician would only be allowed to register for only one subgroup per 10. And that for that, we really are not necessarily seeing the value of allowing multiple registration, allowing a clinician to register for multiple subgroups, in that there is additional reporting burden if a clinician is reporting through multiple means. So we are proposing that they be limited to one subgroup. Next slide, please. With relation to subgroup scoring, we are proposing something related to administrative claims, in that we would calculate and score the administrative claims measures at the 10 level. So this would be at the affiliate group level rather than at the subgroup level. And this affects the foundational layer measures, which are the population health measures that are the multiple chronic conditions and a hospital-wide readmission measure, in addition to any administrative claims-based measure that's within the quality component of an MVP. And also, this also impacts the cost measures, which are administrative claims-based and are found in every single MVP that is available. The last subgroup related policy that we're proposing is related to the subgroup final score. We are proposing to not assign a score for a subgroup that registers but does not submit data as a subgroup. So as I mentioned before, if subgroups register and then come to find that they're not eligible through the second run of the eligibility determination, or they come to decide that they would want to continue to report traditional MIPS instead, we would not hold them or penalize them because they did not report as a subgroup. Next slide, please. Okay, and I'll touch on the MIPS proposals now. If we can go to the next slide. Okay. With regards to our performance category weights, quality and cost as mandated by statute must be at 30% respectively for each one. Improvement activities is at 15% and promoting interoperability as at 25%. So as Katie had indicated in earlier slides, a MIPS is made up of 4 performance categories listed here. So the points of each of these performance categories are added together to then give you a MIPS final score. And based on that final score, a clinician or group would receive either a positive, negative, or neutral payment adjustment. Next slide, please. With regards to the performance category weights, there are no changes from 2022 to the 2023 year proposed rule. You'll note that there are some changes between between the APM entities for traditional MIPS and what their performance category weights are versus that of the APP. And that's just something to keep note of as you are tracking to these requirements. Next slide, please. For the third-party intermediaries, we are proposing a few proposals, some of which are related specifically to the QCDRs. So for the first proposal is specific to the qualified clinical data registries and related to their qualified clinical data registry measure testing requirements. So beginning with, we are proposing to delay the full measure testing requirement up until the 2024 performance year. And this is really in light of the feedback we've been receiving related to the lack of testing data available, especially during the public health emergency. And so we feel that we would want to then delay this requirement until calendar year 2024. However, that proposal, the requirement that QCDR measures be fully tested before implementation in an MVP has not changed. So we will continuously expect that any QCDR measure that is proposed within the MVP is fully tested before we finalize that QCDR measure within the MVP. With regards to the QCDR measure specifications, we have proposed updates to the current language to provide QCDRs with the clear timeline for posting QCDR measure specifications, such that 15 days after we post the approved QCDR measure specifications, the QCDR must publicly post their specifications and provide a link to where that information is posted. And that really just ensures that the information is in alignment with what we have approved, and also that stakeholders and interested parties have access to those QCDR measures and can understand which QCDR supports which measures. With regards to our remedial action and termination policies, which affect all third-party intermediaries, we have proposed to add additional criterion that corrective action plans must address. And this really affects just those third-party intermediaries that are placed on a corrective action plan. With regards to the QCDRs and qualified registries that have been participating in the program, but have not submitted performance data over the past few years, we have proposed that beginning with the calendar year 2024 performance year, we would terminate those QCDRs or qualified registries that are registered to submit, that have been approved through a participation plan to continue to participate, but have failed to actually submit data. So over years, we've been observing that QCDRs and qualified registries who have been approved to participate in the program and support MIPS reporting have submitted no data year over year, but continuously want to be approved as a CMS approved vendor. We don't really see the value of having vendors continuously be approved from an operational standpoint. There's burden associated with continuously having to monitor third-party intermediaries who do not submit data to us. And so we would ask those third-party intermediaries, the QCDRs and registries, to then submit a participation plan on how they intend on having more clients submit data through them to increase their clientele. If nothing changes after a year of that participation plan being implemented, then we would question whether or not they should be a QCDR registry in the future, and we would terminate their participation. And that covers, I believe, all the slides I am covering. If we move to the next slide, I will turn it over to my colleague, Lisa Marie Gomez. Thank you.
Thanks, Sophia. I will be discussing the proposals relating to the quality performance category. Next slide, please. So the first proposal I'm going to discuss relates to our inventory of quality measures. So for the 2022 performance period, we had an inventory of 200 measures. And for 2023, we're proposing a reduction in the total inventory of quality measures. So we're proposing a total of 194 quality measures for the 2023 performance period. And part of the total inventory includes new measures, measures that are being removed, and measures that are substantive changes. So for the measures that we are adding 9 quality measures, including 1 new administrative claims measure, 1 composite measure, 5 high priority measures, and 2 new patient reported outcome measures. We're also proposing substantive changes to 75 existing MIPS quality measures, and we are also proposing additions and removals of measures from specialty sets. We are proposing a removal of 15 quality measures, and we are proposing partial removal of 2 quality measures. So when we mean by partial removal, we mean that 2 measures proposed for removal for traditional MIPS and proposal for retention of 2 measures that will be used in MVPs. I just want to highlight that QCR measures are approved outside the rulemaking process and are not included in this total. Next slide, please. I just want to highlight and discuss our next proposal, which relates to benchmarks for administrative claim measures. In the 2022 final PFS final rule, we did not we proposed policies, but we did not finalize those policies. So our current policy is that measures with data in the historical baseline period defined as 2 performance periods prior to, let's say, the current performance period, use a historical benchmark. And those without a historical benchmark will have a performance period benchmark calculated given that they meet the data completeness and submission volume thresholds. So in the 2023 proposed rule, we are proposing to exclusively use performance period benchmarks for scoring administrative claims-based quality measures. So that is the only proposal that we have relative to benchmarks and how they're being established. Next slide, please. Now I'm going to discuss our proposal relating to data completeness. So in the 2022 final rule, we maintain the data completeness threshold of 70%. And so the 70% data completeness threshold has been in use for various years. And so what we're proposing in the 2023 PFS proposed rule is to increase the data completeness, but that would not start until 2024 performance period, and it would continue through the 2025 performance period. So again, I just want to highlight that for the 2023 performance period, the data completeness threshold will be maintained at 70%, but we are proposing to increase it to 75%, and that will not, again, begin until 2024 and would continue for 2025 performance periods. Next slide, please. Now I'm going to discuss high priority measure definition. So we're proposing to modify the high priority measure definition. Currently, the definition includes outcome, or including intermediate outcome and patient-reported outcome quality measures, appropriate use quality measures, patient safety quality measures, efficiency quality measures, patient experience quality measures, care coordination quality measures, and opiate-related quality measures. So we are proposing to expand the definition of high priority measure to include health equity quality measures. Next slide, please. Now I'm going to discuss a proposal to revisions for the CAHPS MIPS survey. So for the CAHPS MIPS survey, we're proposing to include case mix adjustment models. So currently, the case mix adjusters include age, education, self-reported general health status, self-reported mental health status, proxy response, Medicaid due eligibility, eligibility for Medicare's low-income subsidy, and Asian language survey completion. So we're proposing to modify the case mix adjuster specifically for Asian language survey completion, and we're proposing to change it and use language other than English spoken at home. Next slide, please. Now I'm going to turn the presentation over to my colleague Ray to discuss proposals relating to the cost performance category.
Thank you, Lisa Marie, and hey everyone. My name is Ray Desatel, and I will quickly go over the cost category proposal. Next slide, please. So for cost, we are proposing to establish a maximum cost improvement score of 1 percentage point out of 100 percentage points available. And we are proposing this to meet the statutory requirements of accounting for improvement in the assessment of cost performance. And so that's actually all I have for cost. And now I'll pass it over to Michelle for improvement activities.
Thank you, Ray. My name is Michelle Peterman, and I will be reviewing the traditional MIPS improvement activities, or IA proposals. Next slide, please. Our policies this year were focused on the IA inventory. We proposed 4 new IAs, 5 modifications, and 6 removals. For the 4 new IAs we proposed, we had 2 in the Achieving Health Equity subcategory. The first one is entitled Use Security Labeling Services Available in Certified Health IT for Electronic Health Record Data to Facilitate Data Segmentation. And the second new IA for the Achieving Health Equity subcategory is titled Create and Implement a Plan to Improve Care for Lesbian, Gay, Bisexual, Transgender, and Queer Patients. We also proposed 1 IA in the Expanded Practice Access subcategory, and that one is titled Create and Implement a Language Access Plan. And 1 IA in the Emergency Response and Preparedness subcategory, that one's titled COVID-19 Vaccine Promotion for Practice Staff. For the modifications, I'd like to highlight a couple of those. First, we propose to rename and refocus CC14, which is currently titled Practice Improvements that Engage Community Resources to Support Patient Health Goals. And it's categorized in the Care Coordination subcategory. We are proposing modifications to move this IA to the Achieving Health Equity subcategory and rename it Practice Improvements that Engage Community Resources to Address Drivers of Health. We believe the Achieving Health Equity subcategory more appropriately reflects this IA's intent, and the updated terminology drivers of health better encompasses both social determinants of health and health-related social need concepts. We're also proposing an updated list of activities that may be used to address the identified drivers of health for this IA. Second, we propose to revise CC13. It is currently titled Practice Improvements for Bilateral Exchange of Patient Information. We are proposing to change the title to Practice Improvements to align with Open Notes principles, and we'll be explicitly requiring engagement in open notes for this one. For the removals, I'd like to highlight the removal of PSPA 30. This one was the PCI bleeding campaign. We found out that this campaign concluded August 31st of 2021. So this I is currently suspended from the program, and as it's obviously obsolete, and it will not be available for completion or attestation for the 2022 performance year, so this year. In addition, we're proposing to remove the PSPA 6. That one is the consultation of the prescription drug monitoring program. This will become duplicative of the proposal to require the query for PDMP for clinicians in the PI performance category, and that one is PI EP2. The other IA removal proposals, they will mostly be consolidated and included in other IAs, so therefore they'd still be available for completion and attestation. All of these proposals may be reviewed in further detail in Appendix 2 on tables A, B, and C of the proposed rule. This concludes our IA proposals for this year. I will now pass the presentation over to my colleague, Jessica Warren, who will be discussing the PI proposals. Next slide, please. Oh, you've changed it. Never mind.
Hi, thanks, Michelle. This is Jessica for the MIPS Promoting Interoperability Performance category. So the next set of slides will cover our proposals for 2023. Next slide, please. So for 2023, we have proposed several changes to the Promoting Interoperability Performance category. First, we propose to discontinue automatic reweighting for nurse practitioners, physician assistants, certified registered nurse anesthetist, and clinical nurse specialists. Next slide, please. We have proposed that CMS will allow APM entities to report promoting interoperability data in the APM entity level, such that they will still have the option to report at the individual and group level. Next slide, please. We have proposed to modify the levels of active engagement for the public health and clinical data exchange objective. With this, we propose to combine the existing options number 1 and number 2 into a single option to be called pre-production and validation. Option 3 would remain, but we're going to rename it option 2, validated data production. We have proposed to require MIPS eligible clinicians to submit their level of active engagement. And we've also proposed that eligible clinicians may remain in option 1 for only 1 year. Next slide, please. For 2023, we are also proposing to make the query of PDMP a required measure worth 10 points. We propose to expand the scope by including Schedule II opioids and now proposing to add Schedule III and IV drugs. Next slide, please. For the health information exchange objective, we propose to introduce a measure called participation in the trusted exchange framework and common agreement, TEFCA. This would serve as a third reporting option under the HIE objective. Next slide, please. And last, for promoting interoperability, we have a few changes to our pointing system. This would include a proposal to remove bonus points under the query of PDMP, a reduction in points for the HIE objective, and the provider to patient exchange objective. We're proposing an increase in points for the public health and clinical data exchange objective. And that's it for promoting interoperability performance category. Next up, we have Zenobia, and she'll be speaking to scoring. Thank you.
Thanks, Jessica. The next couple of slides are related to proposals for final scoring that are in the 2023 final rule, proposed rule. Next slide, please. The first of which we will be discussing are related to facility-based measurement. As a reminder, the facility-based measurement policies allow for clinicians who perform most of their services inpatient to be scored using a inpatient value-based purchasing program. The first proposal related to facility-based measurement relates to the complex patient bonus. The complex patient bonus is a bonus that's added to the final score for clinicians that treat a high proportion of medically or socially complex patients. Current versions of the complex patient bonus policy do not discuss how the policy interacts with facility-based clinicians. And currently, there is a requirement to submit on one measure, but there is no requirement to complete the quality data submission requirements. As a result, we are proposing this year to allow for individual facility-based eligible clinicians to be eligible for the complex patient bonus, even if they don't submit data for one MIPS performance category. This is consistent with the facility-based measurement policy that doesn't require a data submission for individual facility-based clinicians. The next facility-based measurement policy is related to virtual group eligibility. Current versions of the rule only discuss groups, and individuals. And this year we are proposing to update that policy to include virtual groups in which 75% or more of the clinicians in the group meet the definition for facility-based MIPS eligible clinician. As a note, virtual groups do not have to submit data in order to be scored for facility-based measurement, which is consistent with our virtual group policy that states that virtual groups signal their intent to participate and be scored as a virtual group. Next slide, please. Next, I'm going to discuss the performance threshold policies. As a reminder, in 2022, we became statutorily required to set the performance threshold at either the mean or median of vital scores from previous years. In 2022, we used the mean score from 2017 and set the performance threshold at 75 points and the additional performance threshold at 85 points. This year, we are proposing to continue using the 2017 performance year mean and setting the performance threshold at 75. Because the additional performance threshold allotment ended in 2022, that additional performance threshold at 89 points is no longer in effect. Next slide. This chart here demonstrates how the scoring and payment adjustments distributions are affected by these proposal changes, noting the lack of an additional performance threshold in 2023. That concludes the final scoring proposals. And next, I will turn it over to Richard Jensen to discuss the advanced APMs.
Thank you. Next slide, please. We have two requests for information in the proposed rule we wanted to highlight. The first is the RFI on quality payment program incentives beginning in the performance year 2023. And we lay out in the NPRM a series of questions addressing the impact on eligible clinicians participating in advanced APM, given the changes that are occurring. I believe there was something earlier in the slide deck that was confusing, and let me try to explicitly tell you the changes that will be occurring. First of all, the 5% incentive payment is in its last year with performance period 2022 related to payment year 2024. It will go away after this year. Next year, there will be no incentive payments in place for QPs. And then beginning in performance period 2024 related to payment year 2026, the conversion factor will be bifurcated. Clinicians who qualify as QPs will receive a 0.75% increase in their payments, and all others will receive a 0.25% increase. So I just want to make clear about those changes in the transition that's occurring over the next couple of years. All of that was laid out in the original MACRA legislation. It's a statutory change, not something that CMS has chosen to do per se. Another request for information we have in our proposed rule is potential transition to individual QP determinations only. Currently, we make QP determinations based on the activity of the APM entity at the APM entity level. And we wanted to get interested parties' feedback on the idea of making that determination at the individual eligible clinician level. There are a number of potential benefits for doing so, and we're interested in hearing from the broader community about that. Next slide. We made a change in how we apply a medical model 50 clinician limit. We're proposing to apply the 50 clinician limit to the APM entity participating in the medical home model rather than the larger parent organizations. For those of you not familiar with this, when we have a medical home model and apply the nominal risk standard that is somewhat less stringent than our generally applicable nominal risk standard, we also apply a 50 clinician limit in order that the lower standard not be taken advantage of. So anyway, you should look at what the changes are we made to this clinician standard, and we are interested in your comments on it. Finally, our nominal risk standard under the generally applicable standard for revenue-based models has been at 8% downside risk, 8% of revenue downside risk. This was time limited through 2024, and we simply have an amendment here that we're proposing to extend the 8% minimum standard out into perpetuity. So that's it for advanced APM, and I think Renee is going to pick up on the next proposal.
Good afternoon. My name is Julie Johnson. Next slide, please. Yes, we have two proposals and an RFI with regards to adding available information on Medicare Care Compare. First, we propose to publicly report commonly performed procedures or utilization data on individual clinician profile pages to aid patients in finding clinicians who may appropriately serve their needs. Adding utilization data on procedures to clinician profile pages would allow patients to find clinicians who have performed specific types of procedures. There are some considerations for the types of procedures we would like to include, such as the procedures misalign with procedures already captured in existing quality and or cost measures. The procedures must be a priority of Medicare patients and caregivers, and where the volume of procedures performed correlates to success or better quality of care given. We also propose to add a telehealth indicator as applicable and technically feasible on individual clinician and group profile pages for those clinicians furnishing covered telehealth services. Adding telehealth indicators to profile pages will help to empower patients' healthcare decisions. For example, those patients living in rural areas or those who are uncomfortable or more at risk with office visits during a wave of COVID-19. As some telehealth codes are time limited, we propose to keep the indicator current by using a 6-month look-back period and refreshing the indicator on clinician profile pages on a bi-monthly basis. Finally, in an effort to advance health equity, we are requesting information about adding additional information to the Compare Tool clinician and group profile pages, such as whether the clinician or group has language services available, speaks other languages besides English, and whether or not they accept insurance outside of traditional Medicare fee-for-service, such as Medicaid, Medigap, Medicare Advantage, and other commercial insurance. Patients and caregivers have indicated an interest in seeing more demographic information on profile pages, including available language services, other languages spoken, and additional insurances accepted. Thank you. And I will turn it over to the next speaker.
Hi, my name is Sabrina Ahmed, and I will be briefly reviewing some of the major proposed changes to the Medicare Shared Savings Program that are included in the 2023 PFS proposed rule. We also have a CMS fact sheet available that summarizes the proposed changes to the Shared Savings Program, and you can locate the fact sheet in the Program Statutes and Regulations section of CMS's Shared Savings Program website. The proposals for the Shared Savings Program are designed to advance the overall value-based care strategy of growth, alignment, and equity. Next slide, please. We are proposing changes to the quality performance standard requirements that are responsive to feedback we've received from interested parties. These proposals are also designed to support the transition of ACOs to the required reporting of ECQMs and MIPS CQMs beginning in performance year 2025 after the sunsetting of the CMS web interface measure set. So beginning with performance year 2023, we are proposing to reinstate a modified sliding scale approach for determining shared savings for all ACOs, regardless of how they report their quality data to CMS. This proposal would allow flexibility for ACOs that fall below the current level of performance required to receive the maximum sharing rate for their track and avoid the all or nothing approach to shared savings. Specifically, if an ACO fails to meet the existing criteria under the quality performance standard to qualify for the maximum sharing rate, That is, if the ACO does not meet the threshold of either the 30th or the 40th percentile across all MIPS quality performance category scores, depending on the performance year, or qualify for the ECQM or MIPS CQM reporting incentive, but achieves a quality performance score that's equivalent to or higher than the 10th percentile of the performance benchmark on at least one of the 4 outcome measures in the APM performance pathway measure set, then the ACO would share in savings, if eligible, at a lower rate that reflects the ACO's health equity adjusted quality performance score. We are also proposing to implement a health equity adjustment of up to 10 bonus points to a ACO's MIPS quality performance category score when the ACO reports all 3 of the all-pair ECQMs or MIPS CQMs, and based on the ACO's high quality measure performance and providing care for a high proportion of underserved or dually eligible beneficiaries. This proposal would only positively impact the ACOs and not penalize them. Additionally, we're proposing to extend the incentive for reporting ECQMs or MIPS CQMs through performance year 2024 to allow ACOs an additional year to gauge their performance on reporting these measures before full reporting of the measures are required beginning in performance year 2025. Next slide, please. So this slide highlights a number of other quality-related proposals and requests for information in this proposed rule. We are clarifying the use of unweighted MIPS quality performance category scores for quality performance standard determinations under the shared savings program. Specifically, we're clarifying that for performance year 2021 and subsequent performance years, we use the submission level MIPS quality performance category scores to determine the 30th and 40th percentile threshold MIPS quality performance category scores in order to establish the applicable quality performance standard that ACOs must meet in order to share in savings at the maximum sharing rate. This is consistent with our original intended methodology of using the unweighted distribution based on submission data to calculate the MIPS quality performance category scores for ACOs. Further, in this proposed rule, we are clarifying that we will reopen an ACO's initial determination to correct errors in the MIPS quality performance category score identified through the MIPS targeted review process. For the CMS web interface measures, we're proposing to establish benchmarks for performance years 2022 through 2024. And we're proposing to score using flat percentages the depression screening and smoking cessation measures for performance year 2022. We're also seeking comment on the addition of new social determinants of health measures in the APM performance pathway for screening for social drivers of health and screen positive rate for social drivers of health. And caps for MIPS survey questions specific to health disparities, discrimination, and price transparency. So this concludes the highlights of selected proposals related to the shared savings program. Next, I'll hand it back to Katie.
Awesome. Thanks so much, Sabrina. And thank you to all of our SMEs today. Next slide, please. I have a couple more things to cover, and then we will open it up for Q&A. It looks like we have a good bit of time, so that's great. Again, same information from the beginning. We're putting up here twice because it's really important. September 6th is that magic date to submit formal comments to CMS for any of our proposed proposals, policies that you've heard today, as well as all of those RFIs that we are requesting information for. So just encourage folks to check all of those out. And again, we have some more information on our QPP resource library with all of our regulatory resources that we've really pulled out all of the main changes that we're proposing just to make it a little bit easier to digest, although I'm sure majority of you have probably already read the rule from front to back. But if you need a resource to help you get through the rule and see what we are proposing, I encourage you to check out those resources as well. And we also made an update this morning to that file, so it now includes all of our proposed MVPs. So it's the exact same information that's in the rule. We just pulled it out into that zip file, so you have it in one place. So if you have any comments, please submit them through the formal process. Next slide. And one more. Oh, I think that's it. Okay, I'm going to turn it back over to Olivia to talk through how we're going to run this QA today. Thanks.
Great, thanks, Katie. So just so everyone's aware, we are now going to start the Q&A portion of today's webinar, and you can ask your question via the Q&A box or through the webinar audio. And just a quick reminder, to ask a question via webinar audio, please go ahead and raise your hand, and we will call on you and unmute your line so that you can speak. And you may be muted on your end as well, so you may just need to unmute yourself as well. So it looks like we do have a few folks with their hands raised, so I think we can start with the phone line. Karen Samuelson, we will start with you. We'll unmute your line and you can go ahead and ask your question.
And real quick before we get started, if folks wouldn't mind just saying their name and if they're with a specific organization, that would be really helpful. Thanks. So again, Karen
it looks
Samuelson. Yep, looks like you might be muted.
Okay. We will move on to the next person. Miriam Moreno Diaz, we will unmute your line and you can ask your question. I think you might be muted on.
Yep. Oh, I think your hand came down. Okay, we will move on to the next person, Kelly Winkleman. We will unmute your line.
Sorry, no question. Thank you.
No problem. Jamie G, we will unmute your line and you can ask your question. And Jamie, you may be muted on your line as well. Okay, we will try a few more folks before moving to the Q&A box. Rick Gawenda, we will unmute your line.
My question is for 2023, for physical therapists, occupational therapists, and SLPs and small practices, will the re-weighting still be 50% quality and 50% improvement, since those disciplines are kind of, quote, exempt from the promoting interoperability and costs like they were in 2022?
Hey, Rick, thanks for your question. Yes, we haven't changed any of our re-weighting policies for small practices. So the same policies from 2022 would still apply for 2023.
Okay, thank you.
You are welcome.
We have a few other folks with their hand raised. Jennifer Gasparini, we will unmute your line.
Thanks. So CMS published corrected quality performance standard historic scores for 2018 and 2019. On these slides, you are saying that they published weighted scores. That was the error in last year's rules. What were the scores weighted for?
Yes, so as we stated in the proposed rule, the we had used the weighted distribution of the quality performance category scores that's used in MIPS for final payment calculations. And the updated numbers we released were based on the unweighted distribution of the quality performance category scores submitted by the ACOs groups and individuals once they've historically been used to calculate the benchmarks for quality measure performance under MIPS and shared savings program.
So weighted for what? For group size or something else? I just don't understand what you mean.
So I would suggest that you submit that as a comment. In the proposed rule, we've clarified that it was the weighted distribution of the quality performance scores in that were used in MIPS for final payment calculations. So if you can submit that as a comment, then we can respond to it in the final rule and provide any clarifications as needed.
Okay, thanks.
Okay, and just one last question for the phone line. Yasser Mahmood, we'll unmute your line and you can ask your question. You may be, looks like you're muted on your end as well. Okay, well, we do have quite a few questions in the Q&A box. Sophia, we'll start off with a question for you. The question reads, when do you have to start using MVPs?
Well, MVPs are hypothetically available beginning with calendar year 2023. You may remember from our earlier slide, we have 7 that we've previously finalized and 5 that we've proposed that to be available in addition to the 7. So if we are able to finalize those 5 in addition to the 7 we've previously finalized, that would be a set of 12 thus far. So we encourage at this point, if you if interested parties, clinicians, groups are ready to take on MVP reporting, early adoption is something we are encouraging at this point for calendar year 2023. And for the next few years, MVP reporting is voluntary. We have indicated in our previous rulemaking cycles that there will inevitably be a point where MVP reporting will be mandatory because we do intend in a future state to sunset traditional MIPS. So we do encourage those specialists that have MVPs available and relevant to them to early adopt. That gives you a better time to prepare. In the meantime, as traditional MIPS is, continues to be available for the next few years, and that might change in a future, that will likely change in a future state. You can also, if you're unsure about reporting MVPs, you can also report traditional MIPS, and we have a scoring hierarchy that will take the better of your scores between MVP reporting and your traditional MIPS score. But we do encourage, even though it's still voluntary at this point, that you adopt early and become familiar with the policies and MVP reporting to help you with an inevitable situation where there will be a future state where only MVPs are available for reporting for all MIPS eligible clinicians.
Great, and just a quick follow-up, Sophia, this next question, if there's a limit to the number of quality measures, what do you suggest as the number of MVPs that will be required?
Olivia, do you mean, is there a limit to the number of quality measures available in an MVP?
Yes, I think.
Okay.
I think that's what they meant.
Okay, as it pertains to MVP development, we don't have a set rigid number as to the number of measures that should be available. At a minimum, we do encourage as a part of the MVP development process, we consider to have at least 10 measures, and that's really to offer those that are reporting the MVP some choices. Our MVP reporting requirements are, from a quality standpoint, that you report on one high priority measure or one outcome measure. So we will look to make sure those measure types are included. But I think we are more wanting to be cognizant to reflect the various clinical practices that are involved in a specialty specific MVP. So we're not trying to be stringent that MVP can only include up until 10 measures. So you'll note that there is some flexibility in the development of MVPs.
Great, thank you. And Richard, this question is for you. Can you explain more about the 8% nominal risk factor?
Sure. In order for a model to be considered an advanced APM, we have 3 criteria, and one of them relates to financial risk. And specifically, we apply a generally applicable nominal risk standard to models to see if they meet the criterion. There's two things we apply depending on the design of the model. We either apply a 3% downside risk for expected expenditures. That's generally what's applied to any model that uses a benchmark, which are most of our ACO and bundled payment models. We also have 8% revenue standard. In other words, does the model, if it's designed around revenue, have a downside risk of up to potentially 8% for the participants? And so that's been in the program throughout, and that's what the 8% relates to, the generally applicable nominal risk standard. And that's the context, and simply what we're doing this year is that there was a limit on the application of that particular standard was going to end after 2024, and we're making it a permanent standard.
Thank you, Richard. The next question reads, does the increase from 70% data completeness to 75% also apply to ACOs?
This is Damon. I think I can respond to that. So the answer is yes, it applies to everybody reporting to MIPS.
Great, thank you, Damon. The next question, we report on all eligible clinicians that are part of our ambulatory practices. As we create MVPs, just confirming that we are still able to report under one TIN for multiple MVPs.
So for the time being, for the way our policies and reporting requirements are constructed, a given MIPS eligible clinician, group, subgroup, APM entity can only register and report for one MVP. So if you have a multi-specialty TIN, within the first few years of MVP reporting, you have some choices. So from 2023 to 2025, you can report as a multi-specialty group as a single TIN in which you'd only report one MVP, because our MVP registration only allows you to register as for one MVP. You can also, within that time frame, choose to form multiple subgroups and have each of those subgroups report on a unique MVP. Each subgroup can only report one MVP. And then when we get to calendar year 2026, a multi-specialty TIN, in order to report MVPs, is required to form subgroups. So the time frame for which a multi-specialty TIN can report as a multi-specialty TIN is only available from 2023 to 2025. Starting from 2026, they are required, in order to report MVPs, they are required to form subgroups. And those were policies that were finalized in the calendar year 2022 final rule.
Thank you, Sophia. And we do have a few other questions for you related to MVPs. The next question, for supporting MVPs, does an EHR need to support all measures under all the different data collection types for that MVP, or are they okay to support ECQM measures only?
Well, we did finalize in the calendar year 2022 rule that third-party intermediaries, which includes EHR vendors, should support MVPs that are pertinent to the clients they support. So if you are a third-party intermediary, for example, that supports only a single specialty, we would not expect you to support all MVPs that are available in our MVP inventory. However, if you support multiple specialties through your third-party intermediary, including as an EHR vendor, then you should support MVPs that are pertinent and clinically relevant to the clinicians you support. With regards to limiting collection type, we did finalize that third-party intermediaries must support all measures within the MVP. What we clarified was only QCDRs can support QCDR measures. So if a QCDR is not a measure owner of a specific QCDR measure, they'd have to request permission in order to support those measures. They're not mandated to, but they can. For EHR vendors, there's a limited likelihood that you would be able to only support the ECQM collection type and have enough choices for clinicians to then meet the quality reporting requirements. Our ECQM library is limited. We try to include ECQMs to the extent we can within our MVPs, but I doubt that there's a likelihood in each of the MVPs that we have and have proposed where you can only support the ECQM collection type and help a clinician fulfill the quality reporting requirements within the MVP. So there will likely need to be an understanding or some kind of expansion of what you support to allow you to support also the MIPS CQMs to then have enough measures available and supported in an MVP for your clinicians to meet the reporting requirements of MVP reporting.
Great, thank you. Sabrina, this is a question for you. Where can we find the percentile curves that show the 30 and 40 percentiles that will apply to ACOs?
Yes, so I just responded to this question, but you can look at table 54 in the rule, and it's the section titled clarifying the use of unweighted MIPS quality performance category scores for quality performance standard determinations under the shared savings program. But if you just search for table 54, it's the proposal is described within that section.
Thank you. The next question is about the cost performance category. It reads, for the cost category improvement, what data is being used to compare the results in 2023 to evaluate for the possible improvement points, since the EUC has removed costs for 2019 through 2021?
Hi, this is Lisa Marie. I'll answer that question. So for this particular policy, what we're proposing, in the event that there are 2 years in which data is available, so 2 consecutive years in which data is available, that's when scoring for improvement would be conducted. So I know that in previous years, cost has not been scored. So if, let's say, it is scored for 2022, but let's say it's not available for scoring in 2021, there's not 2 years of consecutive data in which data is available. So the only time that a cost improvement score would be applied is in which there are 2 years in which data, 2 consecutive years in which data is available.
Thank you, Lisa Marie. And one more question for you, Sophia. Has the mechanism for subgroup registration been finalized yet?
We are in the midst of ironing out the details of the subgroup registration process. So we are intending over, I would say, maybe the next few months to work on additional guidance materials, and we intend to have some documentation and support available through our QPP website related to subgroup registration and the mechanics of that. So I will say there's more to come.
Great. And I know we are almost at time, but we do have a few folks with their hands raised. So Andrew Webster, we will unmute your line and you can ask your question.
Hi, thank you for the information. 2 questions. The first being that you're with the change to the unweighted MIPS scores for the percentiles for ACO quality performance standard, will that speed up the reporting of the percentile? And the second question is if you'll have any additional webinars on the full suite of ACO changes.
So regarding the first question, so once we are done with our calculations of the thresholds based on, for the historical information, we will be publishing that information in the Shared Savings Program website. So I cannot provide any specifics related to timing, but once the numbers are done being calculated, we will be posting them on the SSP website and announcing to the ACOs of the availability of the threshold.
Thanks, Sabrina. And I think we have time for one last question. Mohan Pillai, we will unmute your line and you can ask your question.
Can you hear me?
Yes, we can hear you.
Yes.
Okay. My question was regarding this blank year where there's no bonus, and it's going to really affect the increased participation in ACOs. So is anyone really addressing this issue, or do you want us to talk about it in the proposed rule?
I can answer that. Hi. Well, we certainly want you to address our questions in the proposed rule. That's why we put the RFI out. Beyond that, I really can't say. As I said, it's part of the statute, and so it's a question for Congress to address one way or the other.
Thank you.
Great. Well, we are at time. So Katie, I will pass it back to you to close this out.
Great. Thanks, Olivia. And thank you so much, everybody, for hanging in there. There was a lot of information. So thank you for your questions and discussion. And please look for our slides and recording in the next couple of weeks on the QPP webinar library. And we look forward to hearing from you all through the comment process and talking to you soon. Have a great rest of the day.